as well as the annular dilatation. But in his description of Eisenmenger syndrome, there was something wrong. Can somebody pick it up from the slide? So he described somebody with cyanosis and shortness of breath, a systolic murmur, who died from hemoptysis. What is wrong with his description of Eisenmenger syndrome? I want you to be awake with me. So I know you're eating, so wake up. So what is wrong with his description? What is wrong in that first paragraph about Eisenmenger syndrome? Nothing to help you? Huh? Murmur, perfect, Rose. I'm glad you're very well trained. So, and he thought the murmur was related to the VSD, but in Eisenmenger syndrome, if you don't hear a murmur in the VSD because of the equal pressure. If you hear a systolic murmur in the VSD that's holosystolic, what will it be? Huh? No. Systolic, holosystolic murmur, not ejection murmur. TR, perfect. It's tricuspid annular dilatation with TR, and he had tricuspid annular dilatation. Good, you're all awake now. So Eisenmenger syndrome was most commonly caused by ventricular septal defect, in which the VSD is large enough to cause significant left-right shunt that nobody closes it, nobody detected it, or nobody closes it. So progressively, with the volume overload of the left ventricle and pulmonary blood flow, they will have pulmonary hypertension that becomes progressive to become irreversible pulmonary hypertension. You'll have pulmonary vascular obstructive disease. The PA pressure goes up significantly, becomes systemic or suprasystemic. The RV pressure becomes systemic. There's equal pressure between the RV and LV, and you have a right to left shunt across the ventricular septal defect, and that's what the patient gets blue. And that's what Eisenmenger syndrome is. So if you do a TE with contrast, you're going to see a lot of right to left shunt from the ventricular septal defect, which is here. Eisenmenger syndrome is less commonly associated with AV canal and ASDs. Only 5% at most of ASDs can cause severe PAH in Eisenmenger syndrome. It is commonly associated with PDA. And what's the sign on physical examination for the PDA Eisenmenger? What's the sign? Perfect, differential diagnosis. But also Eisenmenger syndrome is known to occur in patients with complex congenital heart disease without PS, like single ventricle. And the hallmark cyanosis. What I want to spend with you the next 20 minutes or so is to demonstrate to you how much of a problem is Eisenmenger syndrome as well as a multi-system disorder. It's not the heart only that's affected by Eisenmenger syndrome. When I see those patients, and my oldest patient is 60 now, we deal with a lot of those issues. In fact, I'm going to tell you his life. This is a patient of mine who just turned 60 in April. And I met him like 20 years ago. He has double inlet left ventricle, as you can see on echo, with Eisenmenger syndrome. I'm going to pick up his life from 10 years ago. I'm not going to tell you before that, I'm going to tell you from 10 years ago. He called me. He said, I'm having a headache and I had the root canal. I took antibiotics like you always teach me to, but I'm not doing well. My doctor gave me quinolone antibiotics and I'm not getting better. And he started having mental status changes and dysarthria, which is a very concerning thing in an Eisenmenger patient. So let's look at his lab. His hemoglobin is 20, his hematocrit is 60, platelet count is 120,000, and MCV is 88. Why is that? Well, in patients with Eisenmenger syndrome or all cyanotic patients that you see in adult congenital arena, because of cyanosis, there's increased erythropoietin secretion from the bone marrow, and they produce more red blood cells. So all cyanotic patients live at a higher hemoglobin. On average, is between 18 and 21 grams per deciliter. Their hematocrit is anywhere between 55 and 64 or 63%. And that's not polycythemia. That's huge. This is not a blood disorder. This is a compensatory erythrocytosis that is needed to maintain tissue oxygenation. So if their hemoglobin is 18 to 21, leave them alone. In fact, I'm going to tell you at the end of the lecture that the best thing to do with Eisenmenger is leave them alone. Don't touch them. And this is one of those features. Now, unfortunately, when you have a high hemoglobin, you have a high risk of hyperviscosity syndrome. It's very well known in the literature. People feel headache, their eyes are injected, they cannot concentrate. Now, until 1996, people used to do a lot of phlebotomy for Eisenmenger syndrome because of hyperviscosity syndrome. They drop their hemoglobin, they feel better, but then they rebound and do it again. They kept on having repeated phlebotomies. However, this is not that good because repeated phlebotomies causes iron deficiency anemia that we demonstrated 20 years ago is associated with significant increased risk of stroke. So we avoid nowadays doing any phlebotomy unless really, really needed, and we replace it with water. The last thing you want in an Eisenmenger syndrome is to have iron deficiency anemia, whether repeated phlebotomies or menorrhagias, because the red cells, remember anatomy or histopathology from medical school. Red cell is formed, the form of a red cell is like a donut, right? It's like at the center is like a compound. While iron deficient cells are spherical in nature, and that's the difference, and they might not be able to go through muscular circulation. So we treat iron deficiency anemia quite aggressively. But the way I do it, if the hemoglobin is less than 18 but more than 16, I might give them an iron tablet for like a month or two and make sure that hemoglobin goes up to 18. I don't want an Eisenmenger syndrome with a hemoglobin of less than 18. That's not normal. That's what we call relative anemia. If the hemoglobin is like 12 to 16, I might transfuse them with blood. Because they're not going to feel good. If they live on a hemoglobin of 18, they are not going to feel good with a hemoglobin of 12 or 13 after a GI bleed or whatever the cause of the anemia is. And we know iron replacement in the right patient, if they're anemic, improves their quality of life and make them feel better. This is the paper. This was one of my first papers in Eisenmenger syndromes. Looking at strokes and Eisenmenger syndrome, 162 patients published more than 20 years ago. It makes me feel old a bit. And the independent risk factors for strokes were repeated phlebotomy with microcytosis, atrial fibrillation, and stroke. And we all know in adult AFib and hypertension causes stroke. So the main finding related to this that changed the way we deal with Eisenmenger syndrome is repeated phlebotomy and microcytosis. So the best thing is to prevent phlebotomy. If somebody has hyperviscosity syndrome, I usually ask them to drink more water, get the volume more depleted. If you have Eisenmenger syndrome, it's very important to put filters on all IVs when patients in the hospital, because you can see air bubbles going through the tubes, and the last thing you want is an air bubble to go paradoxically through the hole. And then when you have somebody who needs to be on anticoagulation, and I'll talk about it later, you need to be really careful about it. What about the infection in Eisenmenger syndrome? This is when Kevin came in. He was infected. Well, infection happens at quite a higher rate because of the cyanosis. And infection happens in the skin, in the lung, in the heart. Up to 10-13% can develop endocarditis. So we really teach our patient to be very careful about skin and dental hygiene, because this is where the portal of entry is, and around procedures. Around 6.5% of all patients with Eisenmenger syndrome will develop endocarditis with brain abscesses. And that's what he had. He came in with mental status changes, not improving on antibiotics. And this is what we did an MRI, and you see the thalamic abscess. So whenever you see an Eisenmenger syndrome who's not behaving well, think infection. Take a blood cultures. You'll never be wrong. And if its mental status changes, do a brain MRI. So we did a brain biopsy and got staphylococcus infection. The echocardiogram didn't show a vegetation, but he was treated with Navcillin, and we put the PICC line because we wanted to give him at least 6 weeks of antibiotics. We treat him with really for a brain abscess, and we drained his abscess. He had an open drain abscess. Unfortunately, what happens with the PICC line? he clotted his axillary and subclavian vein. So why? Why do patients with Eisenmenger syndrome clot? Unfortunately, there are clotters and bleeders in the same patient. They clot because of the cyanosis and the changes in their clotting factors. And it's very well known that they have in-situ thrombosis in the pulmonary arteries that happen as they get older, especially if they have dilated pulmonary arteries and they have biventricular dysfunction. This is a patient of mine who had a clot in the PA, and you can see on CT scan in up to 20% of patients. So these patients can clot. So what are we going to do? We're going to heparinize, right? So we started heparin, and I made sure that the APTT is not more than 55. Why? Because these patients bleed, and I want to make sure that you anticoagulate them enough, but not too much. And because of the problem with clotting, with bleeding in these patients, the clotting factors are reduced, factor 2, 7, 9, and 10. The von Willebrand factor of normality, the platelets are reduced to 120,000 with the normal more than 140, and they have abnormal platelet function as well. So all of these predispose to bleed. So they not only clot, but they bleed. And okay, we give him heparin. What happens? He had massive hemoptysis. This all happened over a 6-week period in the hospital in January of 2008. So he started having large volume hemoptysis. Hemoptysis occurred in around 1/3 of the patients. We used to think that it is a common cause of death or a sign that they're going to pass away. This is not the case. They really do okay after hemoptysis. Most of the time, it's a small bleed, not the major bleed like Kevin had. And these are the common causes of hemoptysis. So if you have a patient with Eisenmenger syndrome coming to the hospital with hemoptysis, you do blood cultures, you do a CT scan and chest x-ray, see if there's an infection, you have to look for the cause. Most of the time, it's this minor bleed from bronchial neovascularization or collateral. And the patients can often tell you which lung it's coming from because they hear the gurgling coming when it's coming up. We don't do bronchoscopies in these patients. It doesn't help us that much, honestly. You can have pulmonary artery dissection as seen on the CT scan here. So please keep in mind the causes of hemoptysis in the Eisenmenger patient. So we often do a CT scan to make sure there's no infection or no masses. We do cultures. If they're taking any antiplatelet agents and non-steroidal, we stop it. We do not do bronchoscopy. If it's a large volume, we do catheterization and try to embolize the bleed. If it is mild, we only hospitalize for a couple of days, give them hydration, give them sedatives so that they don't cough too much, and we rarely do anything. And most of them will become really, they go away by themselves. But he had a large volume hemoptysis. We ended up embolizing 4 bronchial collateral bleeders. And he did okay, he survived it. This was now 10 years ago, he survived brain abscess. When you consider anticoagulation, Eisenmenger syndrome, these are the categories of, if you have atrial fibrillation, you really need to anticoagulate. And we use warfarin all the time. If you have documented in-situ pulmonary thrombosis or PE that can happen around 20%, yes, you anticoagulate. If you have a stroke without any evidence of microcytosis or any identifiable cause, that you treat with anticoagulate. If you have repeated DVTs, because of the risk of paradoxical embolism with the right to left shunt, you treat with anticoagulation. Or if you place indwelling catheter or pacemakers with a residual shunt, that's why we don't put endocardial pacemaker lead in these patients. We don't. We put subcutaneous or epicardial pacemaker. What about the heart? Well, arrhythmias occurs quite often in these patients. It could be atrial or ventricular, but predominantly atrial arrhythmia. Ventricular arrhythmias are not common unless you're later in the disease. You're old enough for the RVA hypertrophy and cyanosis to cause VT. So we start them on antiarrhythmic medication, but we have to be cautious about the kidneys and the liver, and we have to be careful about it. Ventricular dysfunction can occur. In fact, Kevin in 2005 had left-sided heart failure. I cathed him, and his blood pressure was 24. So I put him in the hospital and started him on Coreg and lisinopril. He has been on it since then. The teaching with Eisenmenger syndrome is that you don't want to give them afterward reduction, because if you drop the blood pressure, you might cause more right to left shunt and they will collapse. But in patients with left-sided heart failure and high wedge pressure, which is not explained by Eisenmenger syndrome, you can put them in a hospital, be very cautious. And he was in a hospital like 2 to 3 weeks at that time with me, and give them very low dose, like 2.5 milligrams of lisinopril, and see what happens, and go up on the dose accordingly. And he has been on those medications since then. What happened to the coronary arteries? The papers and research suggest that these patients don't develop coronary atherosclerosis. They're large coronary arteries that tortuous, which is fine. But we have started noticing something in these patients, which is compression of the ostial left main coronary artery by the dilated pulmonary artery. This is a patient of mine. He didn't have it, but this is 38 patient of mine with ASD Eisenmenger. She was having chest pain with ST changes. You can see the ostial left main, how narrow it is at the tip, just at the ostium. And we did intravascular ultrasound. You see the compression is caused by the dilated PA that is hypertensive. The dilated PA by itself is not enough. You have to have a very hypertensive dilated PA to compress. So we put a stent in and see the difference at the ostial of the left main. And the intravascular ultrasound confirmed it. I had 3 or 4 cases, and I didn't report it. It was my mistake, because there's a paper written just last year looking at this and identifying how often you see these patients with a compression of the left main by the dilated PA. And the predictor by CT scan is a pulmonary artery, main pulmonary artery size of more than 4 centimeters. And then Eisenmenger syndrome predicts the presence of ostial left main that you can stent and do well after. Well, he didn't have chest pain. He didn't have an ostial left main. He had 1 episode of VT. He was complaining of palpitations, and I put a monitor on him, and it was VT. He was asymptomatic during that time, but I wasn't that comfortable with VT, because VT is a common cause of sudden death in these patients. So we ended up putting a subcutaneous ICD. That's the safest ICD you put in these patients. It doesn't help with anything else. It's not a pacemaker. It's just an ICD. And he hasn't had an event for 6 years. All this ICD interrogation doesn't show any more VT. Sudden death in patients like that. The common cause of death in Eisenmenger is sudden death followed by heart failure typically, or something we do like surgery or non-cardiac surgery. VT can occur because of coronary ischemia, or because of left main compression, or they have bad habits with smoking and develop coronary artery disease, or simply the big, thick hypertrophy right ventricle with subventricular ischemia. But they can also die from inside the pulmonary thrombosis, dissection, and PE, from bleeding into the brain, or the last thing you want is for them to be in a hot shower or be dehydrated and taking drugs or Viagra, for example. That's the worst thing, because they're going to drop dead. Although you can use sildenafil for pH, and we'll go over that a bit later. So let's go over the rest of his lab. His creatinine was 1.6 and uric acid 6.5. What does it mean for an Eisenmenger syndrome? Well, patients with Eisenmenger syndrome do not have normal kidneys. Most of them do not have normal kidneys. They have a form of hypercellular congested glomeruli with thickened basement membrane. So when you do an angiogram in these patients, we hydrate them quite well before and after. We avoid non-steroidals, and really be concerned about any drug that can cause kidney dysfunction. This is very important. It's very common for these patients to have an abnormal kidney function. What about gout? Well, if you see some of those patients, you know that uric acid is high, because they increase production because of the high hemoglobin, right? They have high uric acid, and the kidneys are not working that well to excrete uric acid, so they have hyperuricemia, they develop gout, and once they have gout, it can be pretty bad. So I've seen gout in the elbows, everywhere. So you treat them like any gout. You give them, colchicine and some non-steroidal if you want. We use a lot of colchicine and prednisone. We don't like to use non-steroidal because of the kidneys. And in between attacks, you treat them with allopurinol and change their diet so that they don't eat a lot of meat and red meat that can cause high uric acid. What about musculoskeletal complaint? Well, scoliosis is is prevalent more than 3 times the general population in cyanotic heart disease. They get some, and that's part of the cyanosis, and it's probably related to the growth factor, vascular growth factors in these patients. Up to 1/3 of these patients will have the digital clubbing, arthralgias, and pain along the long bones, as you can see that they have some periostosis, as you can see in this picture. And if you do a bone scan, they will light up. So they can have pains, and you have to be careful about how to treat them, not affecting the kidneys and not affecting any bleed. Gallbladder is the same thing as gout. With high hemoglobin and high erythrocyte mass, you see a high level of bilirubin unconjugated that causes calcium bilirubinate gallstone and gallstone attack. If they're asymptomatic, I would leave them alone. Again, the best thing is to leave these patients alone. If you have symptomatic, then you have to have the best surgeon who can operate the quickest way and take the gallbladder out and relieve symptoms. And I will talk about non-cardiac surgery. Non-cardiac surgery has been reported to be very risky in these patients because of the changes in the heart rate and blood pressure around and the bleeding at the time of the surgery. So the initial reported series showed the mortality of up to 23% if you do non-cardiac surgery, such as gallbladder or even tubal ligation, because we don't want women to be pregnant with Eisenmenger syndrome. And again, related to bleeding and thrombosis and changes in blood pressure. But in our experience, we didn't see that. So this was another work that I did early on, looking at our Mayo series, and we reported only 7% mortality. Now, the difference between our patients and the other reported series is that at Mayo, we're very picky with the non-cardiac surgery in Eisenmenger. If I'm going to send a patient for gallbladder surgery or whatever, I make sure the anesthesia is done by a cardiac anesthesiologist. And I make sure that based on this paper, we had only 1 death. And remember that patient very well. She was coming from Italy, and she wanted to have scoliosis surgery because her figure was not that great with scoliosis. And we tried to convince her, no, I'm not going to do like a plastic surgery just because you don't look that good with. And she insisted, she started crying, said, I would prefer to die. Her surgery was 6 hours long, and that was too much. That's the only death we have had at Mayo with Eisenmenger syndrome, having non-cardiac surgery. So the risk of death and complication was related to the length of the operation. So nowadays, what we recommended at that time in 1999, almost 20 years ago, if you're going to do surgery, non-cardiac surgery in Eisenmenger, let the cardiac anesthesiologist, those who do the cardiac anesthesia for cardiac surgeries, use short-acting preparation, put an Artline, make sure the blood pressure is stable, put filters on IV, make sure there's no air embolism, and be careful with heart rate and blood pressure management for the first few days after surgery in ICU. We don't put PA catheters. You never put PA catheters in these patients. In fact, the recent reported series showed only a 3.8% mortality if you do these. They followed our guidelines and they reported a 4% mortality only at most. So what I've tried to demonstrate in the past 15 minutes or so that Eisenmenger syndrome is indeed the multi-system disorder that affects not only the heart. Although we are cardiologists and we take care of the heart, but when we see those patients, you have to take care of everything else. So this is a multi-system disorder. So the management is clearly best done by ACHD expert or pediatric cardiologist to see those patients. And you want to also some expert with pH, because you are going to treat these patients with pH targeted therapy. Not to improve survival, I can promise them they can walk better. Their 6-minute walk test and the quality of life is better. So the management, I'm going to show you 3 slides that practically is avoiding what I call the do not harm approach. Stop smoking. They cannot eat a lot of salt because they go into heart failure. They can go to they have to avoid going to Denver and high altitude place because they get short of breath and they can go on pulmonary edema and bleed. But they can travel on flights as long as the cabin is pressurized, and most flights are cabin pressurized in commercial flights. I saw a patient who was like 46 and never flew a plane because he had been told you cannot fly. And I thought, no, you can't fly. So his first flight was like half an hour flight with his mom and dad. The second flight with his wife for like 3 hours, and now he goes to Europe every time he wants to be on vacation. It's a myth that these patients cannot travel. Yes, they can. Don't do phlebotomies and avoid iron deficiency anemia. Avoid doing volume depletion because they're not going to do that while they will become hypertensive. So no saunas, no hot tub, no excessive alcohol use, and really hydrate well before procedures. Avoid strenuous exercise up to the level of exhaustion. I want them to walk, I want them to bike, I want them to exercise, but don't push yourself to the limit. Take care of the skin and teeth, see the dentist every 6 months, make sure you don't get infected. Make sure you're very careful about medication that you take and how they can affect your blood pressure. Never put an endocardial pacemaker lead. Use an epicardial system or a subcutaneous lead. And if you're going to avoid non-cardiac surgery in pregnancy, 50% death with pregnancy, and I can talk about that tomorrow during the pregnancy session. And avoid non-cardiac surgery. But if you're going to do non-cardiac surgery, go to a place where they have cardiac anesthesiologists and specialists who can take care of you. The 2018 guidelines that were published in August, and I just went over them this morning, had a small section on Eisenmenger. They say you have to check their saturation when they come and see you. Don't check them when they walk into the clinic, but check them after they rest for 5 minutes. And the reason why is that the outcome depending on saturation. If you have an Eisenmenger syndrome whose saturation is more than 85%, or they do a lot better than those whose saturation is 80%, it's a sign that they're not going to do that well if their saturation is low. Meticulous intravenous care. We put filters on all IVs because you want to avoid air embolism in these patients. As I said before with Kevin, if anybody has a headache or they don't feel good, do an MRI of the brain. Make sure it's not a brain abscess. Take blood cultures. Look for uric acid and treat gout when needed. I would say less than 20% of my patients with Eisenmenger syndrome don't use oxygen. There's a 20% or so who use oxygen because they feel better. Remember, if you have a condition and you take oxygen, nasal cannula, and their oxygen gets better, it's not Eisenmenger syndrome. Eisenmenger syndrome cyanosis because of an intracardiac shunt. An intracardiac shunt is not going to get better with giving them oxygen. It's probably related to something in the lung that improves their oxygenation. So if they feel better, fine, give them oxygen. But if they don't feel better, don't give them oxygen. Again, avoid anything that can cause hypoxemia. If they give them sedation, they will not feel that great. Cardiac anesthesia for non-cardiac surgery, avoid pregnancy, you can travel. And one thing about the blood test, if you're doing an INR on these patients, you should tell the lab they're cyanotic because they have to mix it in a different way than normal people. The mixtures of the blood test, because they will give you erroneously high INR in these patients. The PDTA, they have to use a different mixture in patients with cyanotic heart disease. So this is what they recommend follow-up in these patients every 6 to 12 months with those tests, and there are guidelines that are available. So what do we do with these patients? The major thing, as I said, do not harm them. The second thing is medication. Fortunately, we do have bosentan, sildenafil, and iloprost, and all those prostaglandins that we can use. Now, what you can promise these patients when you use them is that their exercise capacity will get better. They will walk better and feel less short of breath. Don't promise them they're going to drop their PA pressure, drop their pulmonary vascular resistance, or live longer. You promise them they're going to feel better, and that sometimes is enough for these patients. Now, the most important thing when you use these medications is to know the side effects. Well, they're going to call you, and be aware of that. The side effect of each of the drug, and we have used a combination. The guidelines that were published in 2018, a few weeks ago, bosentan is a class 1, sildenafil is a class 2A, because bosentan, the first trial, the BREATH 5 trial, was on bosentan. And we use it often. I have many patients who are on triple therapy, in fact, nowadays, with macepentan and bosentan and sildenafil. So, know the side effect so that to be aware of that. This is a great study that was published in 2016. Look at 153. That's the largest Eisenmenger study that was treated with pH targeted therapy. Around 18% were on dual therapy. And at the meantime, when they changed from one drug to two drugs, was around 2.5. And the multivariate analysis showed the following, showing that oxygen saturation got better, the 6-minute walk got better, but survival appears to be better. The 5-year survival in those on pH targeted therapy was 83%, compared to 60% in patients with no pH therapy. So it looks like observational study showed that survival is better. But remember, these are not randomized clinical trials in which we give the drug to check and see if survival. It's retrospective analysis. It's an observational study. But if you look at survival in patients with Eisenmenger syndrome, when I was in training in 1994 and now, it's significantly better. So that's the latest data from 2014. 194 patients, and the survival is more than 80% at 20 years of follow-up. So this is remarkably better compared to before, because we know a lot more about Eisenmenger syndrome than we knew in 1994 when I was in training. And we know what to do and what, in fact, what not to do in these patients. Leave them alone is much better. So in summary, you can live well with Eisenmenger syndrome. Yeah, patients with that syndrome are going to have a multi-system issues, as I demonstrated with Kevin. And I tell him, I share this story all the time, and he's okay with me using his first name. These patients should be referred to an ACHD specialist to take care of them, not only for the heart, but also the other organs. Consider bosentan or sildenafil, whatever is available for you here that's cheap for the patient. Do 6-minute walks, escalate therapy. When I escalate therapy, I sometimes do a characterization to make sure that it's documented. I usually do not start pH therapy before. I do a CAT before you start pH, and that's a class 1 indication. And tell them that they might live better with medication, but the most important thing, they are going to feel better with the drug, with improvement in their 6-minute walk. Thank you for your attention.
Thank you, Dr. Amash. You have given an overview and very good point to be recognized as a during treatment of the Eisenmenger